Let's talk about pancreatitis. Pancreatitis, it refers to an inflammation of the pancreas, usually the sterile. They're usually sterile. Okay, meaning it's not due to some bug or anything. Let's talk about acute pancreatitis. Acute pancreatitis is an auto digestion. Oops, where did I go? Alright, going back here, yeah. You have an auto digestion of pancreas by pancreatic enzymes. Looking in picture A, yellow arrow. So they mean to show us pancreatic enzyme in yellow arrow. That's what I mean. Wow. Well, I should wear some nice radiological goggles, I guess, to see some yellow arrow pancreatic enzymes. So let's just think here, these are the pancreatic enzymes, okay? Surrounded by edema. Okay, yeah, we can see that. So look, we have the digestion of the pancreas. Let's say this is the pancreas. We have the digestion of the pancreas, and that pancreas, surrounding that pancreas, we have edema. And you can look edema. Let me just erase that so you can have a look. Edema surrounding that. What are the causes to it? We have the idiopathic, not known. Gallstones, very important. Gallstones, very important. Ethanol, very important. Ethanol, very important. Trauma, steroids, mumps, autoimmune diseases, scorpion sting, very important. No, I'm just kidding. Scorpion sting. Hypercalcemia, hypertriglyceridemia. Hypertriglyceridemia, very important. If you have greater than 1,000 triglyceride levels in your bloodstream, then this can cause acute pancreatitis. But otherwise, if you have less than that, don't even think about it. ERCP, while you're going up all the way, you damage the liver. You damage the pancreas, causing autodigestion of the pancreas. Drugs, sulfa drugs, NRTIs, protease inhibitors. I get smashed is a good mnemonic, but I don't know how you can remember that. Okay, just remember the gallstones, ethanol, steroids, trauma to the pancreas, mumps. Okay, yeah, pretty much. Diagnosed by two of three criteria. You have an acute epigastric pain, often radiating to the back. Very important. Epigastric pain always goes straight to the back. The way it's going to be explained as pain that goes straight to the back. And epigastric pain, abdominal pain going straight to the back. That's a pancreatic pain. It's a serum amylase or lipase. Lipase is more specific for pancreas, to the upper to the limit to the normal or characteristic imaging finding. Complications, you have the pancreatic pseudocyst. Why pseudocyst? Because it is lined by granulation tissue, not the epithelium. It would have been a normal cyst or pancreatic cyst if it was through epithelium, but nah, it's more of a granulation tissue that looks like an epithelium, but it is not an epithelium, calling it a pseudocyst. Okay, that's important that it is the granulation tissue. Abscess formation, necrosis of the pancreas, hemorrhage, infection, organ failure like acute liver injury, ARDS, shock, or renal failure. In organ failure, renal failure. Hypocalcemia by the precipitation of calcium soaps. So let's talk, how does this calcium soap? So normally what you have is, well, how do we have hypocalcemia? Because of calcium deposition, right? So what's happening is here, let's just explain this thing, very important point. So what's happening here, you have the fat necrosis. So that autogestion of the pancreas is of the pancreas. And on the side of the pancreas, you have the fat. You have the fat necrosis of the peripancreatic fat. So anyways, when you have the fat necrosis of the peripancreatic fat, which fat? That is peripancreatic, right here. What causes that, what leads to the formation of, whenever you had this peripancreatic fat necrosis, it caused a release of free fatty acids, right? Free fatty acids, which would lead to which leads to calcium gets bound to them. When calcium's bind to these things, it forms calcium soaps. Okay. And because calcium is being used up here, that's why you have hypocalcemia. Okay, that's how you have the hypocalcemia. Pseudocyst, let's also talk about that here. Pseudocyst, it is a collection of fluid and enzymes and inflammation debris, right? Collection of fluid and enzyme debris, collection of fluid in that pseudocyst. It would present as, now this collection of fluid is going to present as abdominal mass, ABD mass. And this can rupture because it's not a true pseudocyst, it's a pseudocyst. It's a granulation tissue. So it can rupture and cause those all enzymes that are present into the abdominal cavity, and that can lead to hemorrhage, right? Okay. Now let's also talk about abscess. How would you have an abscess? It is due to E. coli would come in and cause an abscess. You have necrosis, and what else? Shock and hypoglycemia, and what else? Yeah. Okay, yeah, that's pretty much all we have. Let's talk about the chronic pancreatitis. And by the way, decreased calcium equals worst prognosis. Now let's talk about chronic pancreatitis. In chronic pancreatitis, so when we had this recurrent acute pancreatitis, it leads to formation of chronic pancreatitis, chronic inflammation, which causes atrophy, calcification of the pancreas. Looking at picture C, look at these white things. They are the calcifications. Major risk factors include alcohol use disorder. Now, too much alcohol every single day, alcohol use disorder. Genetic predisposition, CF, and spin K1. We did talk about the spin K1 in our physiology lectures. And can be idiopathic. Complications include pancreatic insufficiency. So this can lead to pancreatic insufficiency and pseudocyst. What is pancreatic insufficiency? That means typically when less than 10% pancreatic function. So basically saying 90% of the function of the pancreas is no more. We call it pancreatic insufficiency. When the pancreas is less than 10% functioning, it is insufficient. may manifest with steatorrhea, fat-soluble vitamin deficiencies, and diabetes mellitus. Amylase and lipase may not be elevated. Why? Because it's only 10% which is working, right? How can we have an increase in amylase lipase when we know that it's only 10%, less than 10%, which is actively working? Almost always elevated in which are in differentiation, which is almost always elevated in the acute pancreatitis, because in their pancreas is 100% working. Okay. Also, what's the treatment for if you have this chronic pancreatitis or pancreatic insufficiency? Treat it with enzyme replacement. Okay, let's talk about something. DXI-Lows. Remember we did talk about DXI-Lows test. So here is going to be normal DXI-Lows test. Secretin is most accurate. Secretin stimulation test. This is the most accurate. How you administer IV secretin, which would normally stimulate pancreas, which leads to large and increased bicarb secretion into the duodenum. But since you do not have this pancreas enough functioning, even if you give IV secretin, you would not see increased bicarb in duodenum. Okay. So you have the important point here is in chronic pancreatitis, you're looking at atrophy first thing. Second thing, calcification and atrophy of the pancreas is called chronic pancreatitis, which leads to pancreatic insufficiency. That means pancreas not working. That means you have steatorrhea, fat-soluble vitamin deficiency, and diabetes mellitus. Okay, great. Let's talk about pancreatic adenocarcinoma. Pancreatic adenocarcinoma is a very aggressive tumor arising from the pancreatic duct. Remember the ducts? These were the acids and these were the ducts. This is a duct. So it was arising from the pancreatic duct, disorganized glandular structure with cellular infiltration, A. Okay, look at this picture, A. So we have a disorganized glandular structures. So disorganized glandular structures, which are, so if this is an SNI, you have this. Okay. Often metastatic at presentation. With average survival is about 1 year after diagnosis. Tumor more common in pancreatic head. Head is the more common area. Looking at picture B. Okay. Associated with CA19-9 tumor marker, also CEA less specific. So CA19-9 tumor marker. Risk factors are tobacco smoking. This is the strongest risk factor. Chronic pancreatitis, especially greater than 20 years, can lead to this pancreatic adenocarcinoma. Diabetes can lead to this. Age greater than 50. Often presents with abdominal pain radiating to the back. Same presentation, abdominal pain radiating to the back. Weight loss because it's a carcinoma due to malabsorption and anorexia. Migratory thrombophlebitis, which is redness, tenderness on palpation of extremities. Trozic syndrome. Obstructive jaundice with palpable, non-tender gallbladder. Korbeuser sign. Obstructive jaundice with palpable, non-tender gallbladder composition if it involves the head of pancreas, if the tumor involves the head of pancreas. On this imaging, you can have an pancreatic head tumor excuse me, guys. Okay, yeah, that's pretty much it for this thing. But what is the treatment? Not that there's no treatment, there's only 1 year survival, but still, what can you give? There's a Whipple procedure in which you're doing pancreaticoduodenectomy. You can give chemotherapy and radiation therapy. Okay. But with Whipple procedure, you only have a 5-year survival rate. For 5-year survival rate is 5%. Okay, that's all for this pancreatic adenocarcinoma.